Good morning, everyone, and welcome to our external consulting webinar series. My name is Tony Chiak, and I serve as the unit head within Management Engineering and Consulting. During this webinar, we will discuss Mayo Clinic's clinical practice expense reduction program called Practice Optimization and Acceleration. This program serves to transform Mayo Clinic's practice for providing the highest quality, affordable care to its patients. The key tenets of the program include care standardization, quality improvement, and expense management. First, I'd like to share some information about Mayo Clinic and our department, Management Engineering and Consulting. In Rochester, we see 400,000 patients per year with 2,380 physicians and scientists, including 125 primary care providers. In the community and regional health system, we have it set up in 4 regions with 18 hospitals, and we are in 75 communities in Minnesota, Iowa, and Wisconsin. The Mayo Clinic Health System sees 525,000 patients per year with 1,400 physicians. At Mayo Clinic in Arizona, we see approximately 115,000 patients per year with 621 physicians and scientists. And in the Mayo Clinic in Florida, we see 110,000 patients per year with 559 physicians and scientists. So here's some background on the Management Engineering and Consulting Department in Mayo Clinic. ME&C was founded in 1947 and have been engaged in healthcare consulting business for over 70 years. Our mission is to partner with clients to achieve the best patient experience through objective, innovative, and integrative business consulting. And our key capability is end-to-end internal and external consulting across practice, research, education, and administration within an enterprise setting. And here are a few details about our staff in Management Engineering Consulting. We have 200 team members made up of health systems engineers, project managers, and support staff. We pride ourselves in attracting and retaining a very diverse workforce. We have been able to attract diversified and talented staff that have lived and worked in 36 different countries. We also have very multidisciplinary educational backgrounds and experience. As you can see, we have people from business administration, nursing, organizational leadership, engineering, finance and economics, and public health. Now here are 5 service lines within ME&C. First is Management Systems and Process Engineering, where we apply a variety of engineering tools to improve business performance, such as Lean Six Sigma, advanced analytics, simulation modeling, and optimization. We help integrate multiple disciplines to study and solve complex problems using a systems approach. The next one is Strategy, Design, and Execution, where we help develop and refine business objectives, define key business measurements, and accelerate design and development of key strategic initiatives. Our next is Change Management and Organizational Transformation. This involves vision design and development, change management planning, and implementation of best practices. Our next is Revenue Enhancement and Expense Management, where we work on business process redesign to decrease operational expense, improve supply chain efficiency, and identify new revenue opportunities. Our fifth is Project Management, where we utilize a structured and disciplined methodology project framework to deliver improvement plans to complex projects. And here's an example of some of the optimization projects that ME&C has worked on. You can see bone marrow transplant, chemotherapy, GI bleed. So there's several that we've worked on and been very successful with. So now I'd like to introduce our guest speakers. Our first guest speaker is Dr. David Larson. Dr. Larson serves as chair of the Division of Colon and Rectal Surgery. He holds the academic rank of Professor of Surgery in the College of Medicine at Mayo Clinic. Dr. Larson received his medical degree from the University of Minnesota School of Medicine and completed his residency and clinical fellowship in colon and rectal surgery at Mayo Clinic in Rochester, Minnesota. Dr. Larson earned his MBA with an emphasis in healthcare. Dr. Larson's research interests includes colorectal cancer, inflammatory bowel disease, laparoscopic colon and rectal surgery, and robotic surgery. Our next guest speaker is Gene Dankbar. Gene Dankbar is a senior principal health systems engineer in the Department of Management, Engineering, and Consulting, Mayo Clinic, Rochester, Minnesota. He is part of a team providing business consulting to help work units discover new ways to help patients and staff. He is a certified Six Sigma Black Belt through the American Society for Quality. His graduate work is in the field of industrial engineering. Now I'd like to ask Dr. Larson a few questions. First, can you give our audience a brief overview of the Practice Optimization and Acceleration Program at Mayo Clinic?
Yeah, sure, Tony. First off, thanks for having me today. It's a great opportunity to be with such fantastic colleagues that are so critical to improving the practice at Mayo Clinic. And Gene and I have been together for years in our own projects in colorectal surgery years back, but he's been an integral part of all the change management that we've gone through over the years. Well, first off, practice optimization and acceleration really represents one of the implementation arms of redesign of the practice for Mayo Clinic. And as most healthcare organizations, there's really no shortage of great ideas. But it's the execution of those ideas where ME&C really shines and presents a real opportunity for the practice to achieve those excellent concepts and ideas. So for practice optimization, there are really four concepts, or the 4 C's, that we like to promote. Mm-hmm. The first C is collaboration. We have to collaborate with the practice. And Gene got me onto this early on. I mean, teamwork up and down the continuum. Every single person that touches the life of the patient has to be involved in that. So collaboration up and down the practice is really critical. Communication. We want to be able to communicate to our bosses and to the frontline workers what we're doing and the benefits that are seen from this kind of collaborative work between our groups. Cataloging. One of the opportunities that ME&C has offered up to us is being able to really catalog and categorize the opportunities that each of these projects represent. Again, being able to put together closure documents so that this learning is not lost but can be used across the practice and diffused. And then finally, a clearinghouse. And this is what, for me, is the most important. Again, facilitating for both the patients and for providers the opportunity to execute on the goals and vision of providers and administrators. And so being that one point of contact for the practice to offer up the skill sets of Gene, offer up the skill sets of yourself, to again enable those visions to come to light. Now, from a very high-level enterprise point of view, we ultimately report to the Mayo Clinic CPC, or Clinical Practice Committee. Now, the Clinical Practice Committee is the highest level practice committee at the Mayo Clinic, and they oversee all practice-related events. Our group particularly has probably saved in the orders of hundreds of millions of dollars, but I think it's not just the dollars that are important, it's better patient care. It's better patient care for the patients, and it's better care for the providers that provide that care to those patients. Most of our projects last between 6 and 12 months. Nearly every one of our projects starts off with a hurdle rate of about $1 million of costs saved. And then the structured part of our program is really important. I think we'll be talking about that later, but we follow a very standardized, structured methodology that I think helps promote the reproducibility of these efforts together.
Great. I wanted to talk about the structure of the POA program. The first is the charter process and its significance. Can you talk a little bit about that?
Yeah, Tony, great question. So management engineering consulting, I mean, you all are critical to this piece of work. And again, it is a very standard methodology. It includes goal setting, change management, diffusion, control plans, very dynamic point of view. And ME&C is absolutely critical to this. I mean, most physicians don't really have this as their core knowledge. So, of course, for me, if you need a colorectal cancer taken care of, I'm the guy to ask. But if you need an engineer, if you need someone with that skill set, then you need Gene Dankbar on your corner. And so one of the opportunities that ME&C offers up to physicians is when we get a project, we send out a core team of management engineers out to those teams to really analyze their project, to really scope it, to help the physician shape it into something that's manageable and ultimately something that they can execute upon. And then we go to fund this project. And Mayo Clinic has been very generous in funding these projects, both at an operational level, but also funding the time for physicians to engage. And I think this is one of the real critical pieces. And in terms of our overall chartering process, we go through the standard planning, execution, and control phases of all these chartering process with very detailed metrics, milestones, and counterbalances to make sure that we're only improving care, again, for patients and both the people that provide that care.
Great, good. Can you talk about you mentioned the relationship with management engineering consulting, but can you maybe further talk about the value we add to these projects and the partnership with you?
So this is maybe a conversation we can have Gene break in here because, as I suggested, you're just critical to the process. Without those kinds of resources, the engineering resources, the analytics, to be able to internally and externally benchmark these projects and really help project manage for the physicians and administrators to be able to get these things done. Because whether we like to say it or not, again, it's not a shortage of ideas. The most difficult piece is to take that idea and put it into action, to be able to make it happen, to manage that process, and then make it sustainable. And this is something that Gene has helped me in my own life in colorectal surgery on, and maybe Gene, you can comment on some of the roles that health system engineers play throughout the practice, which is just so critical to these projects.
Yeah, exactly right, Dr. Larson. It's exciting to work on these kind of projects, and we work with these clinicians and allied health staff and administrative staff that, again, do come with a lot of ideas and bring it right to the project team as well. And it's an easier project when we come in and they have 5 or 10 ideas we'd like to try, and we just needed the time and the energy and the emphasis by the organization to spend time working on improvement. I mean, our day-to-day work, Dr. Larson, at Mayo and across healthcare across the country, we're so busy. I mean, trying to find the time to work on these projects, and your comment about the organization supporting our clinical staff and our administrative staff to see that improvement is an important part of their job as well. It's just super beneficial. I got to tell you, when we get a chance to work with these teams and they make themselves available for us to spend time, explain the practice. We'll talk a little bit here about the TAVR procedure in a few moments, but I didn't know what a TAVR was going in, but for Dr. Sandhu and Nakomo and Dr. Kevin Greason from cardiac surgery to sit down and explain the procedure and the challenges they have, but some of their ideas it's rewarding. It's a pleasure to work on projects
well,
like
again,
this.
Gene, you're changing lives for the better, and this is why we're all here, to change lives.
Our clinicians, Dr. Larson, are just amazing people to work with, and they're always out there, again, looking for new ideas, new innovations to bring back to the practice for that.
Absolutely.
Yeah. And I think it's key, too, and the thing you mentioned is actually funding time for physicians. I think that's a great thing that Mayo Clinic does.
Well, it's one of the real blessings that the Mayo Clinic has offered up to its staff, and not only physician time, but again, the resources that you bring to the table. And there's such a huge return on investment.
Yes.
And it sets up these projects to live on and do other projects. Again, it's a continuous improvement piece that once they learn how to do it, and you're teaching them,
right.
Management engineering consulting is teaching us how to do it right. They do other projects. And we are offered up continually to go back to the well, to go back to these excited physicians and leaders to do other projects, because again, they have such a good experience with your group that they just want to do more. And that's really been our history.
Good, great.
And see, even spread it to the allied health staff as well, Dr. Larson. I mean, you work with a great team of nurses and therapists and pharmacists and social workers and chaplains, and they're all engaged, in this process. And your leadership of these efforts and your colleagues' leadership really helps bring everybody into that fold, and they bring out the best ideas for everybody as well.
Oh, absolutely.
So,
again, the people that do the work, they know the problems, and they have a good idea of the solutions. It's just helping to give voice to those individuals, and again, your team is just so facilitating and able to do that, to offer up that voice to the people that are doing the work, that it makes everything better.
Yeah. Interactive clinical leadership engagement. When you're showing up there at a 6:30 meeting before going into surgery, that is that sends a great message to the team that this is important work, everybody, and I'm here to help and listen and do whatever I can to remove any barriers or obstacles or communicate this message to the right leadership.
Absolutely.
You came in a snowstorm one time for our project team's meetings, Dr. Larson, so battled 12 inches of snow in Minnesota.
So you have to be prepared for that in Minnesota.
Well, that's true, too. You were there, though. You were there.
Yeah, no, your leadership has been great in this projects. Maybe the next question, with your structured approach to expense management, can you talk about the 6 key pillars that you look at with all projects?
Sure. So again, all of these projects center on standardization. Without standardization, it's really difficult to effectively do these projects. So I think that's a key piece. Obviously, patient engagement is very important. On the part of the business side, of obviously operational inventory expense management, which you had mentioned in the opening monologue. Care team optimization. Now, that is one that we're doing more and more, and that is just so critical. We all know that healthcare is very clerically burdensome. We want to make sure that everyone's operating at their top scope so that we're doing things that are valuable in our own career and helpful for patients. And by optimizing these operational expenses, by optimizing these care teams, we're really able to improve productivity. And it's not about working harder, it's about working smarter. And those opportunities really come forth with the engineering skill sets that you bring to the table and help educate our care teams about those principles. The last piece is really coding and documentation. Again, we're in a business and we want to be paid for what we do, and these opportunities are all around us, and every time we see them, we try to take advantage of them. But I think beyond just the financial outputs, I think it needs to be said that not everything in medicine can be measured. And not everything in medicine has a dollar value, but we know it's the right thing to do. And those right things to do have to be both celebrated and encouraged. And I think the partnership that our committee has with Management Engineering Consulting allows those right things to get done.
Great. Anything to add, Gene?
It's been interesting, as we take these projects and take these lessons, learn forward. With the benefit of our team, Tony, being part of these projects, we can kind of identify other institutional resources to bring to bear for our project teams. We have a big place here, Dr. Larson and Tony, and sometimes not everybody knows all the different professionals and all the different skill sets we bring. And I think with our lessons we've learned over the years, we can bring forth that we got expertise, information technology, facilities management, patient education, are critical things that not everybody has the easy or awareness of that access. Dr. Larson always reminds us when we think about resourcing our projects, don't forget about nurse abstraction out of quality management services, a key resource we have here at Mayo that not everybody is totally familiar with. We're a place here in Rochester of 35,000 people and 60,000 across our enterprise. And again, POA and groups, make sure we are aware of these great resources we have on site here that are available in other organizations as well. It's just tapping into those folks that are willing to be there to help out. They bring some great skills to the table as well.
Well, Gene, it's one of the things that Management Engineering Consultant, at least internally, for certain brings to the table because you have such a history here. I mean, there's almost nothing that your group hasn't redesigned at the Mayo Clinic. And so that history and knowledge that you bring to the table, again, allows us to share across the practice. And those opportunities to diffuse and scale those great ideas, to make it a standard, not just here in Rochester, but across the enterprise, that's the best opportunity that we can provide our patients.
And I think, over the years, we've really developed a very structured approach to be able to diffuse across the enterprise.
Right.
I mean, to all the different hospitals and clinics.
From my standpoint, that seems to have become more mature over the last several years for certain. And I would assume that's your feeling as well.
Oh, yeah. And it's amazing where you find these best practices.
Right.
They're everywhere.
Right.
Okay, great. Can you talk a little bit about the financial parts of the program?
Sure. So again, early on in our beginning of our POA process, finances are an important part, and obviously it's part of our sustainability efforts. We have to ultimately get to better health, better care at a lower cost. And so this is really critical. And in general terms, it's very easy at a high level to understand the costs of healthcare. I think when you start getting into the micro level, but it's a little bit more difficult at times, but at a macro level, it's fairly easy. And so we use these opportunities to really follow projects. Again, we know how much a day in the hospitals costs us. We know how much an ICU day. And we use these to help shepherd and monitor, measure, and feed back to the practices and how they're doing. And we do it not just for their project, but we follow projects for up to 5 years. Now, some of our institution and at a smaller site, more of at a micro level, we may use simple things like charge to cost ratios to try to, on the back of a napkin, understand how much things cost or how much resources we're putting into projects. Or we can use very complex methodologies like TDABC, which is time determined activity-based costing. And these kind of lean methodologies, TDABC methodologies can be extremely helpful. Again, Gene's going to talk about TAVR, but a lot of the complex cardiac ICU practices, lots of branch points in decision making. These TDABC efforts are really valuable in identifying what is really needed and what can be removed, what is valuable, what can be let go, what is new that we can add to again increase that value equation for patients and providers.
Yeah. And Gene, you've done work with TDABC recently.
Yep, we're working on some work right now with orthopedics and anesthesia.
Yeah.
Process there too, which is that's probably a whole project by itself for a future webinar. Dr. Larson and Tony, very exciting work that's underway in anesthesia and orthopedics for some of the work they're doing right now. Maybe in 6 months, Dr. Larson, or a year, maybe.
Absolutely.
Future calendar.
Absolutely.
That's an exciting one.
I think, Tony, if I could just add one other thing, it's not just the economics of the project itself. I think it's the commitment of the institution to the project. Now, most of our projects, as you know, they have a return on investment of at least 10 to 1. Now, if anyone at this table had an opportunity to invest in something like that, we would do it every day of the week.
Yep.
They also invest in really that face-to-face time. So again, we have a big organization across multiple states. And if there's opportunities for physician leaders in the same project, for your own staff as you engage physician leaders and administrative staff, we want you to have face-to-face communication. We want you to be there, be present, be a part of the practice, embed yourself, really learn, as Gene already outlined. He didn't know what a TAVR was, but over the course of the project, he learned.
Yep.
And he learned what the practice has. And again, that's bringing that engineering skill set right into the practice, that greater understanding, that time commitment just is so important to get the results that you want.
Yeah, I have to admit, every time a project comes in, I have to YouTube the procedure so I understand it.
Yeah,
I do.
And would you agree, Dr. Larson and Tony, that your ongoing interest and commitment, I know you're doing phone calls behind the scenes to the project leaders, I know you're talking to them in the operating rooms about how things are going, you're asking us to come back on a quarterly basis and status reports. I think that shows you're not just like, here's your project and we'll see you in a year. I think you have a touch point, and I don't know if you do that consciously, Dr. Larson and Tony, with the POA committee, or if that's built into your process about touch points, encouragement. Surely some of these clinicians have to come back to clinical leaders and say, can we just put it off for 6 months? We're busy right now. I mean, surely, but your ongoing enthusiasm for getting this project done has to help as well for that.
Well, it has become part of our process, and I think having that standard methodology is important, those touch points.
Yeah.
The beauty of most of these projects is, we're not coming into practices saying you have to change. We're coming into practice and asking them, what do you want to change? What do you want better? What are the problems that you face? Yeah. And usually high-functioning people, they have no shortage of being able to say, there's a problem here. And it's wonderful from my standpoint, I'm sure yourself, is when we can say, well, we've got some resources, we've got some very talented people, we've got time for you, and if you want to do this project, we're going to fund you. Yeah. And again, the results speak for themselves. Hundreds of millions of dollars of benefit economically, and it's really uncountable the type of practice improvement and patient care improvements that we've seen over the last few years.
Great. So how do you make sure project teams sustain their gain?
And well, again, those sustaining pieces really are built in, I think, for the HSEs, the project managers. This is part of our process over 6 to 12 months. Again, we want to try to build that in. And so that the administrators and physician leaders at Mayo Clinic, we have a dyad model where physician leaders are partnered with administrators, so that they have a good understanding of what you need to manage and metric the things. And we know that if you don't measure it, you can't manage it. So this is really an important piece that I think over the years has become stronger for management engineering and consulting. And then on top of that, we do follow these projects for 5 years. Now, I don't look at that as following these projects because 5 years is a long time and these projects probably become stale, but it's more important that we just have a touch point with the groups, with the practice, that we can call them back in and say, how are things going? Are there new projects? And more often than not, the practice says, oh yeah, we got another thing. Okay. We got this issue. And again, it's going back to the same well. I mean, strong physician leaders, strong administrators, great nursing staff. Gene's already mentioned, great advanced practitioners, pharmacists. At every level, there might be a new opportunity to engage. And we want to be there for when that opportunity arises, and we want to be there to support that opportunity to actually see the light of day.
Great. So what does the ideal structure look like in healthcare to help support and sustain clinical process improvement?
Yeah, good question. Well, I'm a little bit biased here. I'm kind of partial to our structure. But if you listen, or if you're a follower of any of the lean management, Tahichi Ono, one of the fathers of lean, suggested that where there is no standard, there can be no continuous improvement. So I think it really starts there, having those standards. And then once you have that standard process, again, Mayo Clinic's a research, education, practice-oriented institution. So there's great research that comes out of this. Nearly every project that we do, the physicians who are part of it, they publish on this stuff. And this published work then gets distributed across the country. And the beauty of that is other practices pick it up. And not only do they pick it up, it offers a base from which to experiment and do new things. And for me as a physician scientist, this is really the betterment and the continuous improvement of patient care in general, and it's the real opportunity that we all have. I think the other piece, which we've already talked about it a bit, is, physicians, what do they need? They need time, and they need the right resources. And health system, your management and engineering and consulting team, you have the right people. You have the right skill sets. You are exactly what physicians need to help implement their vision. So that having those resources for physicians and administrators is really the key.
Great, good.
Dr. Larson, are you seeing at a national level more acknowledgement and recognition of QI projects at your professional society meetings as you travel across the country and across the world? Are you seeing more posters, seeing more oral presentations where clinicians like yourself are sharing not only their significant research work, but systems work that they've improved as well? You're seeing more of that?
Oh yeah, absolutely. That kind of systems mentality. I mean, again, you're an engineering background, so you're an expert in systems, but it's not individuals. Okay. I mean, anyone in healthcare who thinks that you're an island, you're not thinking clearly. I mean, it takes a lot of people to take great care of patients. And so you have to have that systematic approach. And certainly it's being seen in the academic world and research. And I think the challenge for us in healthcare, I always go back to one of my own personal biases. My senior partners published a series on NG tubes, which are nasogastric tubes in patients, in 1989, but it took till 2009 that they finally stopped using them, even though their randomized controlled trial suggested that they should stop using them in 1989. So it's the speed of change. But I think today our speed of change is much more rapid, and we're learning how to translate that science, that effort, into actual clinical practice in a much more rapid way. And engineers like yourself and your whole team has helped shepherd us in that direction.
Great, good. Have you seen other organizations that have a similar model for supporting clinical departments? And are there any lessons learned from those organizations that we can learn from?
Well, again, I would say there's lots of shops. Most of the ones that the individuals listening to this cast would likely know would be lean shops around the country that have multiple groups. Geisinger would be one example of such groups, and they're doing excellent work. There's no question. What I would say is probably the most important for the listeners today is that this methodology is diffusible. So one example in my own life, and Gene was a part of it, so I appreciate his comments. We took our Mayo Clinic Care Network, which is a group of hospitals that are aligned with the Mayo Clinic and partnering with the Mayo Clinic to share ideas. We took our enhanced recovery pathway, which is a complex pathway of both preoperative, intraoperative, and postoperative care of colorectal surgery patients, and we taught them about this to 8 different institutions around the country. We taught them the methodology, we taught them the process, we taught them how to do it, and again, it was really largely based on help from management engineering and consulting. And each one of these groups, to the letter, each one of these groups went back home, implemented a version of those pathways, and changed lives, lower length of stay, reduced complications. And again, it wasn't difficult. It took some coaching, it took some time, it took some face time, some teaching, some educating. But again, collectively together, we were able to change not only the practice here, but we were changing the practice in other institutions around the country. And again, Gene, please comment on that experience yourself.
Well, of course, the other part of that as well was we had our frontline experts right there in the room. And when you see the passion of the frontline staff, nursing and pharmacy and social work and surgical operations and AIM admissions, they were there sharing the story, sharing the passion, and being transparent about that, Dr. Larson. That also helps make this program successful for that. So it's people willing to share, and the passion that our team brings to that was a big factor, I think, as well.
Great.
Great work.
How has POA function evolved over the past few years, and what's changed during your time in the leadership role?
Sure. So, Tony, since you've been a part of this for a long time, you'll have to keep me honest on this. Obviously, the scale and scope have changed significantly. We've only gotten bigger, but the principles have stayed the same. And in terms of scale and scope, when we first started years ago, we were looking at 3 to 5 projects in a year. And usually these projects lasted about 24 months, actually. Yep. But over the years, last year we did more than 50 projects at nearly more than $1 million saved for each project. And these projects last between 6 and 12 months. So the speed of being able to implement these visions, the total scale and the commitment that the institution has to these projects has only increased. And I think over the next 3 to 5 years, that commitment's only going to double. So I can see in 3 to 5 years, get ready, Tony, for more work. There's no shortage of work around here. That we'll be doing more and more, and we'll just be accelerating that speed of delivery.
Yeah, and I think you've pushed the team too to be much more structured and just putting in, here's what the project life cycle is going to look like. Here are the milestones. People are going to hit it. You hold people accountable, and I think you've done a great job over the years to really build a nice program. And, we continually look internally at our own processes. We're redoing our POA playbook, which has all the kind of roadmaps to do these projects.
And for us, too, that is part of continuous improvement. We have to look at ourselves in the mirror every once in a while and make sure we're doing the right things at the right time. And so that structured approach, again, Gene and yourself have brought that to us, and it's only benefited the institution as a whole.
Yeah. Dr. Larson, did you consider slowing down at all the last year and a half? Because we've had this little thing, a little EHR change in the last couple of years. Did you consider scaling back or slowing down at all? And how did you bring that to the clinicians that we still need to continue this work?
Yeah, well, again, in general, we're still moving forward.
Okay.
Epic is a big change. We're all excited to have just gone through that. We're nearly over a month in and doing well. So, but I think this only accelerates new opportunities.
Okay.
Again, changing tools has changed some of our processes, and some of these projects that we've done here recently, are already raising their hands and saying we want a new look to how do we maximize the Epic opportunities that we have through that tool, and their processes and merging the processes with the tools. So to me, I think it's a big opportunity to again accelerate even more the care. And then because we're big, we are staging our Epic rollout. So we've strategically chosen to do more projects in the Mayo Clinic health system, which had an earlier rollout, or newer projects in the southern sites of Florida and Arizona. So we're moving our resources around strategically to try to maximize our time with them prior or after the Epic rollout.
Okay, good point. Yeah, good point.
Yeah, and being on one platform, Epic, that'll help a lot with our standardization and hopefully simplify things.
Oh, absolutely. I mean, again, we've put in a tremendous amount of effort as a practice to try to standardize across the enterprise, and I think this will only help our system.
Yeah.
Good.
What does the ideal structure look like in healthcare to help support and sustain clinical process improvement?
Well, maybe Gene can help answer that question. Do you have a bent on how we can even improve what we're doing today?
Well, again, if you have the local departmental leadership fully engaged in this process, so it's on their dashboard, their radar screen, so it's always something they want to sustain over time. I think that's the key there as well. So it's because leadership changes. So when you go back to in 5 years for some of these projects, Dr. Larson, has to be a new leader in that department chair spot. And if we can find ways to put it on their radar screen, on their dashboard, and it's something they're measuring and tracking and looking at over time, I think that's where I've seen the best examples of projects that have sustained themselves wholeheartedly over time. So again, it's back to leadership and the interest and the passion, and to continue to want to make it even better over time.
That's one of the great things that you all have taught us and it's part of our communicating plan. Some of these projects do such fantastic work, but we're such a big organization. How do you move something that is totally diffusible and scalable, and make sure that every chair, every practice chair, every high-level committee knows about it, and we start putting it on, as you say, on their dashboard. Make that top of mind.
Yeah. Great.
We're even getting articles in our internal news center. I mean, I've seen a lot of profiles of projects that have been completed over the years that get it out to our 60,000 staff members, and that sparks interest as well. Out there, hey, I saw you're doing something in Florida about this. Let me call you up collegially and talk more about it.
Yeah,
I like
absolutely.
seeing that as well too.
All right, we're going to switch to Gene, your presentation on the TAVR.
Okay, let me just share as an example one of the projects that we recently completed here on the transcatheter aortic valve replacement, or better known as TAVR project. This is an opportunity that we recently completed here, and it's a really remarkable procedure. I'll tell you a bit more about. Again, as Dr. Larson, I mentioned Dr. Larson. I didn't know what a TAVR was, had to look it up as well when this project came my way. But this is a project that my colleague, Dr. Brad Williams, the project manager, and I worked on. Let me just give you a brief background on TAVR at Mayo Clinic, the opportunities we identified as a team, the role of myself as a health system engineer and my colleague Brad Williams as a project manager on the team, the interactions we have with the practice optimization acceleration team that I alluded to earlier and how helpful that was, and then talk about some of the results and the next steps that this team is moving forward on as well. TAVR, for those of you who are unfamiliar with it, is really a remarkable procedure in today's healthcare world. It's a valve replacement, where it's a minimally invasive procedure that replaces a aortic valve that fails open properly. So our surgeons and cardiology staff and clinicians will thread a valve up your femoral vein, artery. I better get that right. I'm the engineer, not the doctor. And we'll thread it up there and implant that without doing open heart surgery. So this is a remarkable procedure for those patients who may not be eligible for open heart surgery or have some other complications that may necessitate doing it this way. It's been a procedure we've been doing here at Mayo Clinic. We did research on it and started back in about 2008. And today, hundreds of patients across our systems get the TAVR, or sometimes called TAVI procedure, and it's helping thousands of patients across the United States as well. It's truly remarkable innovation that clinicians and researchers have brought to our attention here. Our project goals for TAVR were, again, as we've been talking about all morning here, reduce the total costs associated with TAVR while maintaining or improving outcome for these procedures at our destination sites here in Rochester, Arizona, and Florida, while also without increasing the readmission rate or impacting mortality and other key measures there as well. Our focus on this procedure was on the supplies to go into this procedure, the procedural location. This procedure initially was done in the operating room, but through innovations and through some research, our clinicians today are doing this in the catheterization lab for the most part. Length of stay was another thing we focused on as well, and also the preoperative processes as well. These patients go through an extensive review of their clinical labs and ability to have this procedure done with them as well. And we were lucky as well for this. Going into this, we had a multidisciplinary team, which is our hallmark here at Mayo. Cardiology, cardiac surgery, administration supporting it. You mentioned the dyad partnership there. Sue Eastman, the administrator, was a key part of this group here. Our nursing colleague, Carrie Sandvak. Supply chain was involved, myself and Brad. Finance also played a big role, telling us where those costs were, where were the opportunities for this as well, and other colleagues and professionals that helped us too. And there's more on this list that we brought in on an ad hoc basis to answer those questions. And it's so nice in our system like ours to call up people and explain you're working on this project and get their help and assistance. It's a remarkable hallmark of work we do here at Mayo. Our methods that we brought to this particular project was active project management. Again, we were able to have regular meetings with the team members across all three of our sites. And I got to challenge you, that was a challenge too, that we have 3 time zones to make those meetings happen. But the team members, the team leadership found the energy, found the time to make themselves be available for this. We were lucky here too to build on existing efforts by the team. As you mentioned, many people have ideas here at Mayo, and many of these improvements that we are working on to diffuse even further were already in flight when they were established across all the sites here as well. Dr. Sandus, Grayson, and Nakoma and others had already started working on these procedures, and we were lucky to be able to build on these and diffuse these even further. We also brought skills around better understanding and documentation of the current preoperative, intraoperative, and postoperative processes as well through simple skills like process mapping and data analysis as well. Again, we are getting better and better data nowadays, and Tony, we're bringing these kind of analytic skills to management engineering consulting, which has been a big help for our clinical teams as well for that. And we were also able to benchmark with other medical centers as well. This was a chance where we actually learned from one of the sites we did some benchmarking was Emory out of Georgia for that. Some of the results that we saw from this particular project were just outstanding. The length of stay for these patients down by 2 days from where it was. The utilization of the catheterization lab up way over 50%, and I called and spoke to Dr. Sandow recently. He said it's up over 90% today as well. They kept innovating up there. The readmissions as we got into this were already declining, and we've been continuing that trend over time. Pacemaker usage has decreased with this. We've established enterprise-wide guidelines, again, for that consistency across the enterprise. And we've also aligned post-procedure guidelines across the enterprise as well for consistency and standardization. My role in the project was to bring, again, helpful early on with that charter development, and it's a living document there. We brought the skills of Lean Six Sigma to this. Stakeholder analysis was a key part of all the projects we do. The benchmarking, like I mentioned, and ensuring we got these individuals to the right committees to make sure we got the right actions we're taking there as well. And as we've mentioned already too, putting in a control plan to monitor and sustain these gains over time was an important element as well. Brad Williams' role as the project manager was there to help deliver the project framework to keep us on track, keep us consistent, and keep that rhythm going to make sure we don't fall behind there as well, to make sure we have a successful implementation across the enterprise. Key business measurements as well, make sure we have procedures in place to make sure that happens there. And again, that partnership with finance is so important to understand where those costs were both before and afterwards as well, and also assisting in putting together a solid control plan so we can monitor this situation over time. Some of the key lessons that we learned from the project itself, again, the value of sharing information across the enterprise, across all sites here, the value of staff gaining an opportunity to discuss improvement at all levels. Again, we brought in team members from the ORs, nursing staff, cath lab, everybody to have an input to this process there. And the important element as well, the focus on the patient experience is always there front and center all the time. And again, every site realized the potential impact of this project. And I'd like to just point out again our interaction with the practice optimization acceleration team. Again, we're the work you did to kind of tee up this project for us, to identify that key leadership, and not only here in Rochester but across the destination site, just helps us get off to a running start versus spending the next 3 months identifying who's going to lead this project. The POA's teamwork up front and the identification was super helpful there. Identifying, allocating the supporting resources that we talked about there. Establishing a timeline. Sometimes that timeline's a little uncomfortable, but it's good to have it there and have a goal to reach toward there as well. Providing milestone meetings along the way to check our progress so we can go back in and see once we complete a project charter, project execution, and control plan, and you're there to help us and lend advice for that as well. I know Dr. Sandhu, Greason, and Nakomo found that helpful as well for that. And again, as I mentioned earlier too, you're always available at pre-OA committee for leadership conversations, addressing project barriers and bringing advice from other projects. And also this idea of maintaining the project financials for 5 years is something, again, we can go back to and touch base with them on a regular basis. So again, a very satisfying project for our staff in ME&C, the ability and the satisfaction of those members in cardiology, cardiac surgery to work on this project as well. I know they appreciate that also in their so that's just a brief overview of one of the many projects. Tony, you shared a list early on, and that's a similar experience we've had with some of those projects as well.
Any comments on the project?
Just a fantastic example of really a very complex, innovative, operative procedure that is, changing how we deal with valvular disease. Right. And we're doing it in unique ways that are safe and effective. And again, changing lives for the better and improving the overall process for all those people that care for those patients. Great. So it's just a really fantastic example, and large credit again to individuals like Gene Dankbar.
Great, good. Yeah. All right, just a friendly reminder to the audience, if you have any questions for the speakers, please enter them in the comments section. Our first question here is, does Mayo use a tiered huddle system?
Tiered huddle system.
I'm not certain what that means.
Would it be part of the care management process, I wonder, part of the care team?
I mean, definitely Mayo Clinic embraces teamwork and huddles. I mean, we have, from the operating room, we have briefings, debriefings at every single operative start on our floors. Obviously, engagement from nursing staff, social work, pharmacy, resident staff, advanced practitioners, and consultant surgeons and medical physicians. That is really part of our daily process on rounds for the hospitalized patients. So
the multidisciplinary rounding, Dr. Larson, is everywhere.
It really is everywhere, and it's been part of our culture for some time.
Great. Next questions. What steps did you take to rally your provider colleagues and institutional leaders to support POA? This is largely what you do all the time.
Well, I look at these as two different pieces. How do you get your bosses and the leaders of the institution excited? Well, success for sure, and we've had a lot of success, and so that's benefited our team, benefited the support that we get from the institution, and again, only accelerated the opportunities. For the front line, I think it's really been making sure everyone understands that we're a single point of contact, that we are somebody that is there to help facilitate their vision. And again, we've said it before, but we're not coming into practices saying you have to change. We are trying to proactively go out to practice and say, how can we help you do what you exactly want to do for patient care? And that, when you come with that kind of attitude, it's much more inspiring, and people are much more willing to engage with you and your teams.
Yeah, when you talk about the size of Mayo Clinic across the nation, having a single point of contact for these projects is so key. Because, I mean, you're able to work with Dr. Harper, and he was the chair of our Mayo Clinic Clinical Practice Committee, to help break down barriers. And I mean, it's just, I think that is key, the structure and the single point of contact.
And it gets very helpful for our institutional leaders to understand that as well, because when they're constantly being asked by practices to help, and they direct them right to us. And we have such a good process and working relationship with your team that we can quickly find out, has this been done before? Is there other sites? So we have internal, external benchmarking. Is this something that we can help on? And if it is, we get to it and help those practices achieve what they want to achieve.
Great. Next question. Why is it important to have outside of the department help with these types of process improvement projects? I think one thing we do well with is bringing in kind of that infrastructure, that project infrastructure, where we automatically assign a ME&C health systems engineer, an ME&C project manager, finance, supply chain consulting, pharmaceutical consultants. I think that's what kind of makes these projects successful.
Yeah, absolutely. And not every department has these resources. So again, if you're relying on somebody to do colorectal cancer, I'm the guy. But if you want an engineer, if you want a management accountant, if you want finance, coding, documentation, quality abstraction, Six Sigma black belts to help you do this, you have to have a core group outside of the department. And management engineering consulting has certainly filled that to a T.
Nothing to add to that.
Okay, great. Next question. How can health systems where the hospital and clinic staff are part of separate organization organize to help promote clinical improvement projects? Well, you guys did touch on one already with the collaboration.
Yeah, I guess, Dr. Larson, we saw that with some of the clinics and hospitals you've worked with, where one organization had relationships with 3 colorectal clinics there. I think from our experience, we just learned that usually you'll find 1 or 2 physician leaders that have the passion to want to try to help the hospital and their whole organizations get better for that. So identifying who those individuals might be and trying to shepherd them, and I don't know how you protect their time or how you get them the resources where they own the clinic. It's the Dr. Larson Colorectal Surgery Clinic. How do you incentivize them rightly to help make that whole system of care from clinic to hospital and back work the best there? That's a challenge, I think. And I don't know if
well, Gene, you were great at facilitating this kind of work, because to me it's about identifying the shared purposes.
That's true. Shared vision.
Shared vision, shared purpose, and you're not always going to align. But let's not go there. Let's go to where we do align.
Yeah.
And although we can't always get 100%, if we're getting to 80%, the majority of the time, we are doing something great.
That's true too.
And so to me, it's all about shared purpose, making sure we get to that. And again, we're a bit lucky here because we have a singular institution. But as to your example, when you don't, I think that's probably the most important piece.
Yeah, I think you're right. Finding that common ground, common purpose, how we're helping both systems get better. And there's a little bit of investment of your time, of your staff at the clinic, to work with the hospital staff to make this all happen there. So I think we'll see more and more examples as we work more and more with Care Network members and other organizations outside of Mayo Clinic on this. So.
Yeah,
absolutely.
This one's for you, Dr. Larson. What have been the biggest lessons learned for you as chair of POA?
Good question.
Put you on the spot here.
To me, the biggest lessons, when I initially came in, I was worried that there wouldn't be enough work, actually. But over time, I've realized that there's just no shortage of opportunity. In fact, the opportunities are so large that, again, it's convincing our leaders that we need more and we need to do more. We've luckily been very successful over the recent past to have more commitment from the institution. And again, that's part of the reason why we've gone from 3 projects a year to more than 50. But our next jump is going to be from 50 to 100. And that does take a level of commitment. But again, we are changing lives, improving the value of healthcare, improving healthcare in general, the cost of care. So it's worth the effort. And luckily, I think we've gotten into a pattern where we've convinced those that hold the purse strings and hold those opportunities to help support our groups.
Great.
That all seems like a great place to. We're not quite at the top of the. I guess we have time for one more question.
Yeah, sure.
That's such a high point. I wanted to end there.
What suggestions might you have for those who are in the early stages of their own POA journey?
Oh, the best thing to me is really have individuals that can scale and scope and identify goals, and honing in on those goals, making them something that can be achievable, and getting early wins. There's nothing like early wins for teams who are already struggling. I mean, they've already identified a problem, so they want to see those early wins. So making sure you got the right goals, you got the right people at the table, you're inclusive, and teamwork is so important. And then making sure we get some early wins.
Good points.
Great. What do you see as the future of our POA program here at Mayo Clinic?
Well, again, I'm kind of partial to it, so I hope it expands and new opportunities to work with management engineering consulting and expanding our work both here and abroad. I think the opportunities and the beauty for the future.
Great. Well, that ends our
well done. Yeah.
Presentation here. I want to thank our guest speakers and everyone for attending our management engineering and consulting webinar. Please feel free to contact us by calling us at 507-284-3424 or visiting our website at mec.mayoclinic.org if you have any questions about our external consulting services. Thank you so much.
Yeah. Thanks, everyone.
Thank you.